My name is Annette von Dregalski. I'm a professor of clinical medicine and the director of the Hemophilia and Thrombosis Treatment Center at the University of California, San Diego. It is now my pleasure to introduce you to the role of point-of-care ultrasound in joint evaluation. I'm using the following abbreviations throughout the talk. That would be POC for point of care and MUSCUS for musculoskeletal ultrasound. How does ultrasound generate images? Well, by now I think you all are pros in that many lectures have led up to this lecture, but just to repeat in a very simple fashion, echoes reflected by tissue structures create an image, and that image is quite anatomical compared to this cartoon here. As you can see, this is the quadriceps tendon here going into the patella. We have the patella itself, the femoral condyle, and here in the suprapatellar bursa, as you see here, a little bit of fluid, and that is separated from the cartilage, which is as hypoechogenic as fluid from a so-called interface line. So for the use of point-of-care ultrasound, there are general principles to be followed, and that's not specific to musculoskeletal ultrasound, but important for all point-of-care ultrasound. It needs to be for a well-defined purpose. It needs to be question-driven, quick. Findings should be easily recognized, easily learned, even by non-radiologists, and be performed at the bedside or in clinic. And my favorite example here is stemming from emergency medicine. It is the so-called EFAST trauma protocol, where with a few transducer positions, as you can see, one can distinguish between blood in the abdomen, pericardial tamponade, or pneumothorax in a fast yes-no fashion. And why is this important? Because they all present similarly but require different treatment, and there is simply no time to move someone through a lengthy CT or possibly MRI scan. So how can we emulate now this point-of-care principle for musculoskeletal ultrasound and translate it into our hemophilia care? Very simple. For instance, for the etiology of joint and muscle pains, all in yes-no fashion. So effusion, yes-no. Joint or muscle bleed, yes-no. Hypervascularity and therefore synovitis or inflammation, yes-no. And then once everyone becomes more familiar with the modality, one can go on like tendon sprain, yes-no, and so on and so forth. MUSCUS helps in terms of precision to guide intra-articular needle placement into complicated joints, and thereby facilitates joint aspiration, but also injections such as corticosteroids. And then finally, even in point-of-care fashion, it can be used for long-term follow-up of joint findings. So POC MUSCUS is truly ideal to answer specific questions related to arthritic symptoms and findings. And why is that? Because clinical presentations in these areas are rather non-specific. So range of motion deficits, redness, pain does not allow to distinguish between different conditions. And that's depicted here by just downloading a number of different arthritic conditions or arthropathies from the internet. And you can see that they all look very similar. So a clinical exam probably won't reveal the underlying etiology, but ultrasound might. So apart from ultrasound now, what imaging modalities are available to us, given that I think we all feel that the management of arthropathic joints, especially in hemophilia, deserves improved diagnosis. Now we have X-rays, and those are clearly not sensitive to soft tissue changes, fluid, or bleeding. We have CT scans, but they require contrast and radiation. And then we have the MRI, which is a long exam. It's inconvenient and it's costly. And in addition, we'll see in a moment, with MRI, it's rather difficult to distinguish bloody versus non-bloody effusions. And so this is where MUSCUS and power Doppler come in very handy. So this demonstrates why conventional or how conventional MRI cannot reliably detect diluted blood. And that was done in our MRI lab with a simple experiment whereby we add mixed joint fluid with increasing concentrations of blood here in a syringe and then MRI'd the syringes. And as you can see here, neither T2 nor T1 weighted images were able to distinguish different percentages of blood. However, the T2 images here could distinguish between fluid and a blood clot that had formed at 100% blood in the syringe within a few minutes. Now again, this is where the detection of bloody effusions with point-of-care musculoskeletal ultrasound comes in incredibly handy, and that's based on two principles. First, compressible spaces with sonopalpation that would identify that there is fluid in the space. And then second, the distinction of non-bloody versus bloody effusions by echogenic characteristics that identify that there is a simple versus a complex effusion. And this is shown in this example of two patients who presented to our clinic with joint pains, two hemophilia patients with acute joint pains. And one of the patients had a simple effusion and the other patient had a bloody complex effusion that was not detected on MRI. And so in this experiment, we first proceeded with ultrasound imaging, and you can see here in the suprapatellar bursa and also in one of the lateral or medial recesses, clear, relatively hypoechogenic or unechogenic fluid in compressible spaces, and compare that to relative complex speckled grizzly fluid in the same locations in the patient with a bloody effusion. This was aspiration confirmed, and then the patient underwent MRI scanning, and you can see that on the MRI in the T2 fluid sensitive sequences as well as in the T1 sequences, there was no distinction between bloody and serous effusions. So how about power Doppler? The power Doppler lets us judge the extent of abnormal intra-articular vascularity, indicating inflammation and vascular remodeling. And I show here 3 examples of patients from my clinic to tell you how useful potentially in clinical decision-making power Doppler can be. So again, power Doppler, you probably have heard about it already in previous lectures, sort of allows us to assess the microcirculation in non-directional flow in tissue structures such as the synovium. So the first patient on top here is a patient with severe hemophilia B. He is 36 years old in his chest status post total knee replacement 2 years earlier. So as you can see here, he has pronounced power Doppler signal around the patellofemoral joint space, and this would be the transducer position for this case. And just as an FYI, you can also see quite some soft tissue, probably synovial tissue proliferation that can be measured with the CHAPE protocol, as we will see a few slides down the line. The next patient, and this by the way is hardware, part of the prosthesis with posterior shadowing or a so-called Comet sign. The next patient is a severe hemophilia A patient. He is 43 years old and he is 2 weeks post an ankle bleed. And here we are imaging his subtalar joint space, and you can see this massive sort of power Doppler signal and inflammation, indicating vascular remodeling and possibly facilitating rebleeding tendencies, since these vessels are quite fragile. And then the last patient here is 25 years old, severe hemophilia A, and this is one of his target joints, but he doesn't report any pain in the joint. But when he images his joint, it clearly shows that there is subclinical bleeding present. This is the posterior olecranon fossa with a complex effusion in this space. But also in the synovial area, you can see some mild power Doppler signal. Now, why would that all be important? Well, look to the right here. you can see that the contralateral side here has no power Doppler signal at all in all positions. And this is in fact normal. There should be no power Doppler signal, not even a few dots. So how did that help? Well, in this patient here, we know that he has some pain, that there is quite some inflammation surrounding the prosthesis, and you will send him to the orthopedic department to look for hardware problems, etc. But once that's all ruled out, there might be a role to put him on anti-inflammatories and see how things develop. In the second patient here, as I already mentioned, post-bleed, these vessels might be very leaky and very fragile. And in a conversation or discussion with physical therapy, one can decide how fast and how aggressive post-bleed rehabilitation should happen. Think about a little kid going out there on the soccer field again, maybe too early, and then suffering from the next bleed. And in this patient here with silent bleeding and also the sort of slightly inflamed, maybe fragile vessel accumulation, we have to do better, maybe with prophylaxis or other clotting factor adjusted treatments in order to move it back to this joint size. You can see that the joint space here is much smaller. There's no effusion in here, no power Doppler signal, and it's a normal fat pad here in the olecranon fossa. So as you can see, having the knowledge of the ultrasound and having the knowledge of power Doppler signal present or not helps quite a bit in making treatment decisions and help management. Then furthermore, POC MOSCAS is very useful in that it enables guided aspiration and injection. So let's stay with aspiration first, and that's best illustrated with a patient. So this patient has moderate hemophilia A. He is young and he just graduated from the pediatric center to our adult center. So one morning he wakes up with spontaneous joint pain, not knowing what this really meant. And as you can see, the presentation here is entirely inconspicuous in that there is no real swelling, some range of motion deficit, but no redness and of course some pain. So within 5 minutes and applying ultrasound, we could see here a effusion. It is complex, as you can see, with small speckles compared to his baseline scan with a small joint space. And that sort of emphasizes how important it is, at least on the hemophilia patients, to have baselines available. And then here in longitudinal axis, even more visible, that complex effusion that's not present in his baseline scan. Here we just see the talar dome with some cartilage and the fat pad in place. So then we continue to aspiration. We take a medial approach, and the take-home message is here we only aspirated 5 milliliters, but with a post-ultrasound scan, which is not shown here, the joint was tapped dry, and saying that a few milliliters of blood can be extremely painful. It doesn't always have to be a big ballooning joint. And the therapeutic effect was quite remarkable with immediate pain resolution from a visual analog score from 7 to 10 to 1 to 10. And the patient was able to walk normally down the stairs, whereas he needed assistance in hobbling up before. Of course, he received clotting factor concentrate as well, but it's just one more thing we can do with the ultrasound now. And that brings us to injections, namely the efficacy of intra-articular MOSCAS-guided corticosteroid injections into painful hemophilic joint. That is a study we did a few years ago in over 40 patients, and you can see that the pain relief on the VAS visual analog pain scale is quite substantial, and most patients experienced a duration of pain relief up to 3, 4, 5 months, but most patients at least 6 weeks. And that's quite substantial if you think about it, since patients kept telling us that they now could do activities that they couldn't do before. They could go on a vacation, they could go on a hike, they could be there pain-free for the wedding of a child, and on it goes. So this is quite meaningful. And to allude to the possibility of corticosteroids being somewhat anti-angiogenic. You can see here in these two examples in the infrapatellar fat pad in the knee and in the olecranon fossa here in the fat pad and in the synovial membrane. The situation before injection was quite some vascular remodeling and vascularity, and the reduction thereof after triamcinolone lidocaine injection. Now, it is unclear if that also is associated with pain relief, but clearly vascularity goes down. And in the case of hemophilia, that might also be important to avoid rebleeding from relatively fragile vessels. So now we come to long-term or longitudinal evaluation of joint status. Well, prior to ultrasound, or even now with ultrasound, we still have, very importantly, the clinical hemophilia joint health score, here shown in demonstration, providing a clinical picture of pain, crepitus, range of motion, etc. Then, of course, we have X-rays, which was sort of a scheme divided or devised by Dr. Pedersen 20 or 30 years ago, with visible changes in the osteochondral domain only because X-rays are not sensitive to soft tissue swelling. And so visible changes here are, in the modern era of hemophilia, too late. One wants to intervene earlier. And so therefore, in the late 2000s to early 2010s, the so-called International Prophylaxis Study Group score was developed because MRI is sensitive to soft tissue changes. However, it's very cumbersome, very expensive, and it would certainly be difficult to scan joints every 6 months or in serious serial fashion. So this is where musculoskeletal ultrasound comes in. And a number of protocols have been proposed in the past, not to overburden you, but there are two principles. One is scoring, which is mostly semi-quantitative, not fully validated in any of the proposed protocols, and it is rather subjective, having ceiling effects. So these scoring mechanisms allow to assess cartilage integrity and also soft tissue expansion, as shown in this example here, looking into the suprapatellar space. And you can see here that scoring goes in terms of extent of abnormalities, the space of abnormalities, and the type of abnormalities. And at the end, there is a score devised. The second principle are direct measurements, and our university developed the so-called quantitative JADE protocol. It's the Joint Assessment Damage Exam. It's fully validated and it is objective. It has no ceiling effects. So one can measure the lengths of osteochondral alterations, one can measure cartilage thickness, soft tissue expansion here in one of the recesses, and one can assess the vascularity and state of inflammation of the joint. So let's stick a little bit with the JADE protocol. There are also other lectures featuring and explaining the protocol, but in essence, it provides direct measurements of soft tissue and osteochondral alterations and the degree of inflammation by power Doppler. The advantages are clearly it's quantitative, it's objective, and there are no ceiling effects, and it can be individualized to the disease of the patient. So give you a case example. In a 21-year-old with severe hemophilia, and he has a Pedersen score of 0, so that tells us there's no osteochondral damage on the X-ray. But then we perform the ultrasound, and you see here to the left a normal ultrasound in a normal knee, and here to the right this patient's abnormal ultrasound. A couple of things stick out. You can see here that in certain sentinel positions there's already cartilage thinning present. Compare that to a relatively normal healthy joint. And then you can see that there's already soft tissue, probably synovium, creeping out of the joint space here in the lateral patellofemoral joint space. And if one measures it out, it's about 3 millimeters, and that's the upper end of normal. Whereas here in this normal knee, you don't see any soft tissue, hypoechoic usually developing in the joint space. So the objective to develop the JADE protocol was a quantitative approach with measurements that are less than 0.1 millimeter and capture dynamic tissue changes that are recognized to contribute to hemophilic arthropathy. The validation process is quite advanced with this protocol and still iterative. And so what does validation of an ultrasound protocol mean? And I think that's very important for all of us in terms of long-term follow-up, applying protocols to joint tissue health, because one wants to know if what one measures is truly what one measures and is correct. So OMERACT has developed a body of literature and guidelines pertaining to ultrasound validation. So OMERACT is an international initiative in rheumatology. It standardizes imaging and it provides clear guidelines for validation. So how does one develop and validate a protocol? So first one has to develop an imaging protocol, and that's usually done by an expert group. It's an iterative process. It can be a nominal process, a Delphi process, but everyone can put together a protocol. The question is, how does one validate it? The cornerstones of validation is the reliability of pathology recognition and discrimination. And pathology, discrimination, and tissue appearance can be very different in different arthritic conditions. What's pathologic in rheumatoid arthritis might not look the same in terms of pathologies in hemophilic arthropathy. So how does one figure this out? Well, easiest are comparative analyses between imaging modalities with a reference method that has already been validated, for instance, through a cadaver study. So let's stick a moment here with the JADE protocol and what that means. So for instance, intracapsular fat can take, here in yellow, can take pathological features. Synovial tissue, here just as a red small line, can obviously proliferate. So it can be present with and without proliferation, with or without fatty metaplasia, with or without hemosiderin, and all of that might look different on ultrasound and needs to be verified by, for instance, MRI or some other modality. And then as a second step, one has to think about development of tissue quantification methods, be it scoring or be it direct measurements, but one has to show that there is intra and inter-rater reliability, that there is inter-operator reliability, and finally, all of that has to be applicable to a clinical cohort. So just showing you maybe my favorite slide here, and that is the recognition of pathology and the extent of pathological tissue discrimination in hemophilic arthropathy with ultrasound. So here we compared MRI and ultrasound findings, and using MRI sequencing conventional but also ultra short time to echo images. And looking here into the suprapatellar bursa of different patients, you would agree that there's hypoechoic, sort of to mixed echogenicity content in these bursas. We just don't know exactly what it is. Special MRI sequences not shown here revealed what it is, and you'll be surprised to see that in this patient it was coagulated blood. In this patient, the suprapatellar bursa had synovial proliferation but no hemosiderin. And that looked exactly the same to hemosiderin-laden synovium. And finally, here we have a trace of fluid, some fat, and also hemosiderin. So the result from this exercise was that ultrasound has a relatively poor discrimination of pathological soft tissues in certain spaces. So in terms of terminology of JADE, we prefer to call it soft tissue expansion versus something more specific like synovial proliferation, because ultrasound really doesn't allow that distinction, at least not in hemophilic arthropathy. On the other hand, the high resolution in ultrasound enables measurements of soft tissue expansion very precisely. So let's, for instance, go here to the MRI. On a conventional MRI in a patient with advanced hemophilic arthropathy, we see here quite some proliferated synovium, and it is laden with hemosiderin. That shows the synovium is black, and it's called a serosignal or blackout signal concealing the synovium. With special MRI UTE sequences, we can resolve that and see really how much synovium there is. Now going to the ultrasound, just putting our probe here into the lateral area and resolving this area with ultrasound, you can see that this hypoechogenic structure here is probably synovial proliferation. So, and the high spatial resolution of the ultrasound now allows to measure this very precisely. So comes out as an average here of 6 millimeters. And that's the advantage of a protocol like the CHADE protocol, because it uses the spatial resolution to really place precise measurements. And then within those measurements or within different treatments, you might follow the resolution of the synovial hypertrophy, which even if just resolving by 3 millimeters might still on a scoring protocol have a very high score, hit a ceiling and not being captured. So to further take advantage of the high resolution for detailed osteochondral evaluation and measurements, and that is depicted here. So here you have a musculoskeletal ultrasound of the so-called sunrise view of the femoral patellar joint space, and below is the MRI. Now you can see here the osteochondral line is somewhat interrupted. It should be just like here to the left of the image, very shiny. And maybe you might ask yourself, well, maybe it's an artifact and I don't hold the transducer quite right. But that's not true. This is the truth. So look at the conventional MRI, and in many ways a bit inferior to ultrasound. This black line here, depicted or denoted by the yellow arrow, is this osteochondral line that we see here. But on the MRI, it looks fairly intact. Only if we take special UTE sequences where this osteochondral line is now depicted in white can you see that it's just shiny here, but here it's very dim and corresponds to this area. So that's another validation how sensitive ultrasound is in terms of picking up osteochondral disturbances or alterations. And so then, of course, apart from these really early and fine signs of osteochondral destruction, we can recognize a wide spectrum of osteochondral abnormalities in terms of cartilage wear, erosions, and osteophytes, as you can see here on this MUSCAS image of a patient with advanced arthropathies with lots of step-offs, interruptions, and very little cartilage present. And this would be the corresponding MRI images. So the CHADE validation continues in terms of inter and intra-rater reliability and inter-operator reliability. And that was shown with 8 experienced MUSCAS hemophilia providers and 23 more inexperienced hemophilia providers who just exited one of our CME classes. So these groups acquired and were reading multiple images, and then the adjudicator was an MSK radiologist, Dr. Eric Cheng, whom you also heard speaking during this lecture series. And not to belabor the results too much, but the results in a nutshell were that there was very good recognition of landmarks and power Doppler signal judgment. Measurements of structures were easily feasible and very reliable and reproducible as to as little as 1/10 of a millimeter. And then, of course, reading abilities improve and converge with training and practice. The 23 novices were not as skilled as the experienced hemophilia providers, but that's expected, and everyone will gain more proficiency as they go along with imaging. And this is an example of the CHADE charting tool. And by the way, this can be moved into EPIC or into an electronic medical record where you just have to click off rather than cross off certain things, and at the end you will get a full automated report. But it shows here the purpose of the image. It shows the landmarks and what it should look like on ultrasound, It provides, you can cross out the description of joint space content, provide an assessment, and then you would chart certain measurements depending on the picture. You would chart the power Doppler signal, chart if it's compressible or not, and here again we have the explanation of the position. And this is the same for another area here, the longitudinal view in the olecranon, where you would do exactly the same, but then just chart the area circumference of the fat pad as the soft tissue component in this image. So moving on to the summary. MUSCAS is valuable for point-of-care assessment of joint and muscle bleeding, as well as other musculoskeletal abnormalities. It improves diagnostic accuracy of musculoskeletal conditions. It enables convenient point-of-care imaging in clinic. It empowers patients to participate in their care, and it enables personalized management of hemophilic joints. Clearly, this modality deserves continued iterative development and validation. And with that, I would like to introduce to you our regular MUSCAS rounds. Please join us. They are for everyone, usually Tuesday mornings at 7:30 a.m. Pacific Standard Time. And they are staged by UCSD, Bloodworks Northwest, and the Indiana HTC. They are web-based. You can share your desktop and case. And if you wish to receive an invitation to that, please email our Marlene Cepeda. She is our ultrasound coordinator, or myself for that matter, and it will take you on the list. And with that, I would like to acknowledge my collaborators, especially in terms of devising the JADE protocol, which is Rebecca Kozayaris and Bruno Steiner in Seattle, Doris Kwan and Cindy Bailey in Los Angeles, and Nihal Bakir in Indianapolis. All of those, to some extent, will also talk to you in the course. And then we have Eric Jang, our radiologist, and Randy Moore, our general musculoskeletal imaging expert. And with that, I thank everyone, not only for assisting in JADE in developing musculoskeletal ultrasound for hemophilia, but also putting together this course. Thank you.